Alright, I'm going to introduce the basics of EKG. However, I want to point out some resources that are way better than what I can ever give you. And the first one is Rapid EKG by Dubin. The other is a great 21 video series by Dr. Eric Strong on YouTube, and it's freely available. And then lastly, I'd like to mention just the website Life in the Fast Lane, which will give you ample opportunity to practice a bunch of different EKG tracings. Now, as I begin, I want to say that unless I otherwise say so, everything I'm referring to in this video is to normal electrophysiology of the heart. I want to give you an example really quick of two different cardiac myocytes, two different cardiac cells. I have one here. We'll call that one a resting cardiac myocyte, and then I'll have another one right here. We'll call this a depolarized cardiac myocyte. So what happens in the resting myocyte is I have a bunch of negative charges on the inside, and I have a bunch of positive charges on the outside. And this is just respective to each other. It's not absolute negative or absolute positive. It's just saying that the inside is more negative than compared to the outside. Then as the heart depolarizes, the inside, the positive charge flows inward, and the inside becomes more positive compared to the outside. And that is depolarization. Just in general, with cardiac physiology, we can think of it as only referring to the inside of the cell, and so we can think of depolarization as the cells becoming positive. It's a wave of positive charge moving through the cells. So if I look at this another way, let me go ahead and give you a couple of connected cardiac myocytes, and we're going to see that initially these all start off being filled with negative charges. And then the depolarization event happens. Let's say it starts right here, and then positive charge will flow from one cell to the next. So we get this wave, this forward movement of positive charge through the cells. So that's what I say here. I say that depolarization is a wave of positive charge, and it's carried by sodium ions, and it causes contraction. So let me go ahead and try to draw you what's happening. So I have my right atrium, my left atrium, my right ventricle, my left ventricle, and I have this intraventricular septum in between. Everything's being separated. And then isolating the atrium from the ventricle, I have my tricuspid and mitral valves, or you could call it the cardiac skeleton. And these things essentially put an electrical conducting isolation barrier between the top and bottom of the heart. And then I have right here what's called the SA node. The SA node is basically the pacemaker of the heart, and it just initially starts off a wave of depolarization through the atrium. So as it depolarizes, the atrium will contract, and it will contract in both. And what you see happening is essentially, if we were to zoom into the level of the cell, we would see that these all started off negatively charged, and then we have this wave of positive charge that came through and caused a contraction. The positive charge initially was sodium, and the contraction is caused by calcium. What you can't see, because it's hard to do in a two-dimensional picture, is that even though the depolarization begins right here and it seems like it's just kind of moving in two directions, it's really moving around into the front and around into the back, and it's moving down the sides. So it's moving sort of in a spherical shape, if you can imagine water dripping down at the top of a ball. So here I have my beach ball, and my beach ball, it's got stripes on it, it's really pretty. And then I drip water, I pour water down on top of it. It's going to drip down every angle all at the same time. And the overall net vector of that water movement will really be determined by if I pour the water straight on top or a little bit to the side, or to the front. The whole net vector of water movement, if I start from the top, the net vector will be straight downward. If I add up the vectors of all of these different movements of water, the overall vector would end up being straight downward. So with the myocyte, the net vector is dependent on two things. It's dependent on, first of all, We want to know where the charge started, so location, and we want to know the thickness of the myocardial wall, so we'll just put thickness. And all of these things will determine net vector. So on an EKG tracing, we have a bunch of different waves that you might notice. The first one, the initial one we see, represents depolarization, and then we get repolarization occurring as this large hump. Now, in actuality, repolarization begins right here, but it's so slow and so negligible that it creates almost a flat line, and this hump represents the fast phase of repolarization. Now, you may be tempted to think that this downward deflection is actually repolarization. It's not. So as we go up on this first part, it just means that the rate of depolarization is increasing and the rate of depolarization is decreasing. So we're still depolarizing right here, just not as much or as fast as we were right there. And typically we can think of flat lines as nothing happening. And so basically that's what I've said here. I've said that depolarization returns to normal as positive charge moves out of the cell. So this is positive charge moving out of the cell, and then we get normal again over here. And I've said that repolarization begins immediately after depolarization, but the broad hump represents the most active phase. So how do we monitor this depolarization and repolarization? The answer is skin electrodes allow us to monitor both the repolarization and depolarization of the heart. The upward deflection represents, the first initial upward deflection represents the sodium, positive sodium charge moving toward a positive electrode. Speaking of sodium, do you got any good chemistry jokes? Nah. How about any jokes about sodium hypobromite? Nah, bro. I'm sodium funny. I slapped my knee on that one. Alright, those were corny, but it's okay to laugh periodically. Alright, let's talk about the SA node. Just as mentioned, I got this image from Wikimedia Commons, and it's open for Creative Commons usage. Right here represents the SA node in this image, and it initiates the depolarization. It's called an automaticity foci. Now, other automaticity foci exist as a backup in case this one fails, but in general, we think of the SA node as the fastest automaticity foci, so whenever it goes off, it resets all of the other foci so that they have to start all over again. So if we think of it as duration of time, the SA node just takes a little bit of time to go off, and this backup automaticity foci takes longer. Every time the SA node every time we get to this point of time, it's going to shoot up and reset that one so that it never actually goes off as long as the SA node is working. And that's basically what I've said. The SA node's the pacemaker. Others exist. They're only as a backup. The SA node initiates depolarization. It's done through sodium. Sodium moves very quickly. Always think of sodium as a fast ion. Think of calcium as a slow ion. And it'll send a stimulus to the AV node. This represents the AV node right here. And you can think of the SA node as the atrial depolarization. So you think of it as basically like you throw a rock inside of water, and it's going to create this wave of depolarization that moves down the atrium. Okay, now it's time to talk about exactly how this is recorded. As positive charge, and we're thinking of positive charge inside the cell, as positive charge moves toward a positive electrode, it's recorded as an upward deflection in the EKG. As positive charge moves away from a positive electrode, it's recorded as a downward deflection in the EKG. As the atrium depolarizes, it creates this little peak on the EKG strip called the Pwave. And because I guess the electrophysiologists like the alphabet really quite a bit, they just named each different deflection by a different letter. So you get the P, Q, R, S, T, and sometimes even there's a U wave. The U wave isn't always there, and so I'm not going to talk about it, and it's a sort of an abnormal finding, and so I'm going to talk about normal physiology in this video. But the gist is we want to think of the P wave as atrial depolarization. And in general, we want to also think of it as atrial contraction. However, the contraction lasts longer than the actual electrical stimulus, but as far as EKGs and stuff go, we can think of the P wave also as atrial contraction. Now the placement of the electrode is going to determine which direction each of these waves go. And so just in general, right now, just think of this as the standard EKG, but you're going to see that different leads, which we'll talk about, are going to lead to different shapes of each of these. So like I said, once we get atrial depolarization, we have a tricuspid and mitral valve that acts as an insulator. And so everything from there on has to go through the AV node. The AV node slows things down. It stops using the sodium as its conduction system. It starts using calcium as its conducting properties, and the calcium is going to move slower. The main reason is because there's a lower concentration of calcium, but also just because of the size and the charge and everything else. I went ahead and threw this slide in here just in case you forgot normal anatomy. Tricuspid is on the trite or the right atrium, mitral, L, left atrium. So I threw this is what I just said. Conduction slows at the AV node. We see a brief pause in the EKG called the PR segment. So we have this little pause called the PR segment, and that's basically the electrical activity is sort of stuck in the AV node, trying to be transmitted to the next section by calcium transmission. So why do we get the pause? Well, as the atrium depolarizes, it's pushing blood into the ventricles, and so we want to give that time, the blood time for that to go in there, and so because the contraction takes a little bit longer than the actual electrical activity, and so that's why it allows a little pause right there. I already said this, also calcium instead of sodium, that's why it takes longer. Conduction picks up speed in the Purkinje fibers. Now what are the Purkinje fibers? It consists of the bundle of his bundle, it consists of bundle branches, and it consists of terminal filaments. Now some books will use a different term. They'll call only the terminal branches, these terminal filaments, as Purkinje fibers, whereas other books will call the whole thing Purkinje fibers. Alright, before we can go on, let's do a really quick anatomy overview. We have from the inside of the heart chamber to the external part of the heart, we have the endocardium, which is basically lining the inside. Then you have the myocardium, the epicardium, which isn't shown on here, and then you have the visceral pericardium and the parietal pericardium. The reason I showed this is because the Purkinje fibers actually basically depolarize from here. They don't actually extend into the myocardium. They depolarize at the internal side of the myocardium. They run just above the endocardium, and depolarization, when it happens, will occur towards the outside. And this is just important to know in order to understand all the vectors and stuff that you're going to see. And so when you see pictures like this, you know that it's not really running in the myocardial tissue. It's actually running just above the endocardium, but that's almost impossible to draw it like that. Alright, so let's talk about lead placement. So what is a lead? A lead, so if we have an electrode, this is an electrode, this is not a lead. A lead is the vector of electrical movement between two electrodes. And so as the ventricle of the heart is depolarizing, the net vector of that depolarization is basically sort of like this way. And so if you do the net vector between the two leads, then you get basically this magnitude of upward deflection. So the upward deflection will be the magnitude of the vector between the two leads. You'll remember when you're looking at the electrocardiogram that you get basically this initial P wave, then you get a pause, and Q, R, S, T. So what causes the initial Q wave? So usually, and I want to remind you that usually if the wave is subjectively small, it's referred to in lowercase letters, and if it's subjectively large, it's referred to in uppercase letters. And depending on what lead you're looking at, and depending on the cardiac abnormalities you might see, the R wave may be small, subjectively small, and you would put the R wave as lowercase. But that's just a convention that you're going to see if you look in the textbooks and stuff. For the most part, I'm going to refer to all of them in capital letters. Now, in the intraventricular septum, which is this guy right here, the initial depolarization usually starts here and moves this direction, and so I put a star there with an arrow to show that. And if you look at the net vector, I'm going to draw the net vector here, the net vector is away from the positive lead. And so remember, positive charge moving away from a positive lead will cause this downward deflection, and that's what the Q represents. And so the idea is that depolarization within the interventricular septum starts on the left side of the heart and moves towards the right side of the heart. And we already discussed the R wave as being basically an overall net vector sort of downward and to the right. And so you get that towards the positive lead, you get that the net vector of the movement towards the positive lead is basically going to be the height of your R wave. But this S wave is a little bit paradoxical, except that you know that the very end, so the timing, it gets to here basically, and then it starts moving back sort of this direction, and so the net vector is away from the positive lead, and that's usually from the top left corner of the left heart. Now the left heart is going to be your main producer of your QRS complex because it's much thicker than the right heart, and so like I said earlier, it's going to be location and muscle thickness that determine the direction and size of the EKG tracings. And you'll also see like maybe it's mostly upward movement whenever you're over here, and I should change the color so you can see this. So it's mostly upward movement. It's a little bit rightward movement, but you can see that over here the the right heart is moving almost completely to the right direction, and so you're moving away from that positive lead. And so I should just mention as a refresher that I'm referring to this as the patient's left and the patient's right. And I think I found a few sources that say that muscle contraction moves the vector as well. I don't think that's actually true from some other things I've read, and just from thinking through that the muscle movement isn't causing a net change in positive charge. It is causing a movement of the location of those charges, but the net change in positive charge happens whenever the ions move, not the muscles. Okay, QRS, it's the ventricular contraction. R wave usually defines everything else. That's not always true, but if you see something that looks like an R wave, then it's probably going to be that's the Q and that's the S. Because the R wave, in many leads, the R wave is the largest. Q wave isn't always present, but when it always is at the beginning of the QRS wave, and the S wave, it's always going to come after the R wave. So Q wave before, S wave after. Then the next thing you're going to get is the ventricles are going to repolarize. So they've depolarized. Now they have to repolarize and get their negative charge back. And that's seen by the T wave. And you're thinking, wait a second, if it's repolarizing, why am I not getting a downward slope? And let me explain that. So typically, let's say we have 3 or 4 cells lined up, and we get depolarization going in this direction. You would think that repolarization would move in this direction as well, but it doesn't actually do that. Repolarization moves in the opposite direction. That's the main idea. That's not 100% true, but the net vector of repolarization is moving in the opposite direction, and so it's going to be a negative charge moving away from a positive electrode, which is also going to cause an upward deflection. So negative charge away from or positive charge toward the positive electrode will cause upward deflection. Now again, repolarization is occurring from the very beginning or from the very end of the QRS complex, but rapid phase is what we call the T wave. So that little pause in between is the ST segment, and that indicates the initial part of repolarization, but it's the very slow and almost negligible part of that. Repolarization is accomplished by potassium ions leaving the myocyte. Next, we'll talk about the QT interval. That's the time in between seeing this cute girl right here. This is my daughter, Sarai. Her first day of first grade was a few days ago, and she's absolutely beautiful. Okay, so the other QT interval is the time between the initiation of the QRS complex to the very end of the T wave. In general, the QT interval is systole. Now I've seen, so for most of the part, the textbooks will say from the beginning of the QRS to the end of the T wave. I've seen some different things where it says that the diagnostic value of using a QT interval for different things depends on whether you go to the end, middle, or beginning of the T wave. But just I think test-wise, you're going to say to the end of the T wave. Now, one of the important things for the QT interval is something called hereditary long QT syndrome, and so if it takes a really long time, and the general rule of thumb is that the QT interval is normal if it's less than or equal to half of the R to R interval. So now's a great time to go ahead and pause this, try to fill in as much of the blanks as you can, and then in 2 seconds I'm going to show you the answer. Okay, so we've mentioned the QRS complex. We've got the P wave, R wave, Q, S, T wave. The PR segment is that pause in between the end of the P wave, the beginning of the Q wave. So this is called the PR segment. It's not called the PQ segment. That's where you can get messed up sometimes. Then the PR interval. So you'll see we have a PR segment and a PR interval. The PR interval is also to the beginning of the Q wave, or the QRS complex. And so again, it's stupid. And then you have the QRS complex, the ST segment, and then something not shown here would be, here's another P wave, QRS, and then from here to here is the R to R interval. R to R interval is basically your way of determining how long the heartbeat takes, and we'll talk about rate and everything later. And then something else not shown here is from the end of the T wave to the beginning of the P wave. This is the TP segment. And I didn't draw this to size or scale or anything, but this basically is the most variable portion of your EKG, and it gets adjusted and changed depending on the rate of the heart. There's one more spot on here that you should be aware of, and it's not mentioned in like the introductory section of Dubin's or anything, but this is called the J point, and this is basically where the QRS complex ends. And the J point is really good in evaluating different things like myocardial infarction and stuff. Lastly, to finish this up is just to refer back to the ions. Calcium causes contraction and slow depolarization of the AV node. Potassium, myocyte repolarization. Sodium, fast cell-to-cell depolarization.